Nick Majerison here, welcome to Top Med Talk. Time now for another in our series of talks taken from EBPOM 2018, the hugely successful meeting that took place at the Institute of Engineering and Technology. This talk is Nial Quiney and it's called The Emergency Laparotomy Collaborative. Have a listen.
Top Med Talk.
Okay, so I think about 2 or 3 years ago, for those who were here, I presented the first part of the Emergency Laparotomy Collaborative, so I thought I'd close the project up and come present it today for you. So just in terms of sources of funding and conflicts of interest, this was massively supported by the Health Foundation, both Shine Award and the Scaling Up Award, and then LIDCO helped in the early stages with training and support for monitors. So I think Rupert or maybe Carol started a pretty similar spot this morning talking about emergency laparotomy, and this is a good place to start. The NHS Network's audit, which was published in 2012 in BGA, and looked at 37 hospitals, and there was this extraordinary, well, firstly, an extraordinary mortality rate of 14.9%, but this massive mortality range of 3.7 to 41%. Everyone in this room knows about this publication. It really stimulated us in Guildford to think carefully about what this meant to us, and this really brought the message home because we had no shame in saying that we were AZ, which is just there. So we had a 21% mortality rate for our emergency laparotomy, which is stunning compared to our elective outcomes, which we thought were some of the best in the country. So it really spurred us on to action, and a couple of us got together. So Carol Peden was involved in this, and Matt Dickinson is somewhere here, but he's definitely helpful. So we put together really a care bundle or care pathway, which we just heard about, and we tried to think of what in terms of the publications that had come out and the evidence which was there, what were the sort of 5 or 6 key things we should try and improve delivery of for the hospitals that might be involved in this. So it's really simple stuff, I'm afraid. So do an early warning score or measure lactate right at the beginning and start resuscitating people if you need to. Give them antibiotics if they're septic. Strange idea, but it's evidence-based. Get people to theatre, we thought, within 6 hours, not delaying to the end of the lists and midnight when leave the registrars to do it. Use some fluid resuscitation techniques to optimise fluid management. We've heard plenty about that today. And admit people to the ITU, because there was some evidence that admitting people to intensive care is beneficial to outcomes. And get consultants involved throughout, so both consultant anaesthetists and consultant surgeons. It wasn't rocket science, but plenty of people called me up and said, what's your pathway? It wasn't difficult. So we put that together. I think someone's mentioned it today already. 4 hospitals across the south of England. And just to sort of summarise, quite an interesting 8-month project. We had historical data, but on the 30-day outcomes, risk-adjusted mortality rate by 38%, and in-hospital mortality rate reduced by 42%. So I was pretty stunned by that data, and people sort of picked that up around the country. But we're not alone in this type of change in mortality rate. So there's 2 publications which you may not come across. These guys, they're both from Denmark. So Moller and Moller, who we met in Birmingham last year, they'd done a study across Denmark looking at peptic ulcer perforation and improving mortality rate. There's a bigger but a similar sort of type of pathway, and they again reduced mortality rate by about 30%. And then Bang Foss, I haven't seen for a few years, but he did a 600 baseline and 600 prospective patients collected in Copenhagen again, and showed again about a 30% reduction in mortality rate. So 3 papers now really sort of talking about the same size of magnitude of reduction in mortality, but all started with quite high mortality rates. So from that, that's the introduction, Emergency Laparotomy Collaborative was born. And so we were really lucky to apply for, Carol Peden helped us get this one, a Scaling Up Improvement Project, which was one of the big grants that the Health Foundation give out to 6 teams a year at that time. We partnered up with 3 groups we'd never worked with before, well, not much anyway. So there's KSS AHSN, there's the Mythical, did you call it Mythical? Wessex AHSN, so they were very good. And the West of England, so West of England, that's Wessex across there. So we had 3 HSNs to work with as partners in crime. So for those of you who are not from these shores, that's quite a big area. That's KSS here, that's Wessex, and that's the West of England there. And if you want to know some numbers, that covers a population of about 8 to 10 million people. There's 28 hospitals were involved. We reckon about 5,000 emergency laparotomies per year. It was a 2-year program we ran, and I'm going to report the data for that just now. We used the model for improvement, and we used the NELA, which is a relatively new organisation in those days when we started, the NELA data to inform us of our progress. So just to talk about what we actually did, We used a collaborative project to improve quality of care primarily and improve outcomes if we could. We used pretty much the same care bundle which you've seen already, and over the course of 2 years we had about 8 to 10 meetings, both locally in some of the AHSNs and as a big group together to talk about a number of things which I'll mention in a minute. I think one of the key things we set up at the beginning was we had a data sharing agreement, and it was a safe space. The data stayed within our group. There was the good performance and the bad performance, but it didn't go outside. If it went outside, it was anonymised, but within the space, everyone knew each other's performance. And we really encouraged learning and spread of good practice. So we spent a lot of time putting hospitals which were not performing well with better performing hospitals and trying to get this exchange of information, because that's where you learn how to improve. We did a lot of ongoing education and coaching on the evidence. QI knowledge was new to many people. Looking at a process diagram of how your system works in your hospital was really like scales off your eyes for many people. We encouraged collaboration and joint working. Leadership was really enthusiastically taken up, so we did a lot about that. And we had a couple of sessions on negotiation, which was excellent. And then towards the end, we thought about sustainability. We didn't have the red, amber, green charts because that implies someone's not performing well. Okay, so get rid of the RAG charts, please. ELC was not a randomised controlled trial, nor was it a means of identifying poor performance, but it was a way to improve performance across the board. Okay, so these are some of the results. I hope you can see them. So we had, in our historical group for 15 months, about 5,000 patients, and over 2 years prospective data collection, 9,200 patients. So there's some interesting data here. The age and sex, there's no real significant differences, but there's definitely a change in the P-possum, and there's definitely a change in the ASA grade, particularly at the low numbers here. Interestingly enough, the accrual rate, i.e. number of patients per month, didn't change. And the lactate and the systolic blood pressure didn't change either. So there's something interesting happening about the types of patients we're operating on a little bit. And in terms of the procedures that were done, there's definitely more adhesiolysis done in the prospective group, just here. And I think this other thing which is significant is this other. And I think people are just getting used to the Nial data set there, because I think people were putting others where they didn't know where to put them. But I think they've been recoded. So there's been a big drop in others, but I think they're probably properly coded. So not a big difference in the type of procedures undertaken. This is the first chart. I don't know if people are familiar with SPC charts. I'll give you 30 seconds talk. So statistical process control. This is the mean here. And the dark line is the end of the historical data. And this is the monthly performance of whatever you're measuring. And if you look at the green, that's 1 sigma, which is 1 standard deviation of spread. Yellow is 2 standard deviations, and 3 standard deviations is the pink one. So that sample there is 3 standard deviations away from the median. If you look, this is the mortality, crude 30-day mortality. It goes along. It doesn't change much, but there's a change down here after about a year of performance. And you'll see the software has highlighted these 8 data points, which shows a highly significant change in mortality rate. And that's according to the Seahart rules of SPC. It's all worked out. So if you want to look at it more easily, more graphically, so our starting mortality rate was 9.8% in the historical patients, dropped to 9% in the first year and 8.2% in the second year. And if you look at risk-adjusted mortality rate, again, there's been a stepwise progressive decrease of 5.5, 5.1, and 4.5% mortality rate. If you think back to that original NHS network trials, there are just extraordinary changes in mortality rate. And then if you look at the length of stay, there's been a tracked change again from 20.1 days down to 18.9 days. It didn't really change much between years 1 and 2. So high-level changes across the board. But the metrics are really interesting, I think. So this is lactate. So this is measurement of lactate. We identified lactate as a means of identifying sick people and then resuscitate them. So before we started, there was obviously a change in performance. That may have been related to sepsis management. There's been a definite improvement in lactate measurement of these patients. This is quite an interesting one, the use of antibiotics in people who are septic. The numbers haven't massively changed, but there's been a stepwise decrease here in that third year. And I'll come on to discussing why that might be in a moment. If you look at the absolute numbers, have gone from about 57% down to about 50%. In terms of getting people to theatre in time, within 6 hours, this is the class 2A patients, there's really sort of, beforehand there was an improvement, then it changed back down, normal didn't really change. It was really just towards the end that a significant change occurred in getting people to theatre in time, which is obviously a difficult thing to change because it's quite complicated. Goal-directed fluid therapy, quite a massive improvement. So we had real resistance, and it's on a geographical basis about whether you should use goal-directed fluid therapy or not. But we spent a lot of time discussing it and looking at some evidence. I've got a great talk about fairy dust you'll be pleased to hear sometime, or not. So after about a year, there's been this big increase in the use of goal-directed fluid therapy, which is pleasing. And then in terms of individual performance, I think there's really impressive changes here. So this is the surgeons. They've gone from a mean of about 87% up to this now, which is well over 93 or 94% here. A real massive improvement in terms of buy-in by surgeons, in terms of getting involved in these cases. And anaesthetists have done it as well. They're not, in terms of absolute numbers, not quite as well, but again, a serious change in people's performance and what they do on a day-to-day basis. This is not Monday to Friday, 9 to 5. This is Saturday, Sunday, Christmas Day, and every other time that you don't want to come to work. Just in terms of those, I think I've got a few more minutes. Those are the mean numbers here. You can see the change for lactate, 63 to 75% pretty much. Goal-directed, 42 to 56%. ITU's got up to 70% now. Consultant surgeons, 94%. Consultant anaesthetists, 74 to 85%. So real big changes in those key parts of the pathway we were focusing on. So overall, we had significant reduction in mortality, both crude and risk-adjusted length of stay. I think we had a substantial change in the metrics. The antibiotics is interesting. I just wonder if that's related to the sepsis sequence and antibiotic stewardship program that was ongoing at the time. I mean, there was a talk at the time, should we just give antibiotics to everyone having a laparotomy before they come to theatre? Well, no. Assess if they're septic and give the right people antibiotics. But 50% or thereabouts is about the right number, we think, from the Nial data. And the quality of care has substantially improved across 28 hospitals. In terms of the causes of the P. possum ASA change, there was a couple of possibilities. Have the patients got better? Well, probably not, because the lactate hasn't changed and the P. possum hasn't changed, so we're not quite sure if that's the cause. Are we diluting the P. possum patients or the ASA score by basically getting more or less well patients into it? But our accrual rate has not changed, so there's not much evidence for that either. Are we not operating the highest P. possum? Are we letting the sick ones die? Well, again, if you look at the distribution of the P. possum, there's no evidence that the 80-90% predicted mortality rate numbers have changed at all, which is something we're going to talk about in about a year's time, maybe, to this meeting. So that's really not quite worked out yet, but I think the change has probably been related partly to change in the patient population, but also changes in terms of the quality of care delivered to patients. So a massive change across a large geographical area, across a lot of hospitals. So what happens next? We're spinning around. So if you're going to Wales tomorrow, we're in Cardiff, and we're starting ELC in Wales. So that's another 14 hospitals are keen to adopt a similar strategy. And I think most people in this room later this year will get a message from their local AHSN, because the AHSN network has chosen ELC as one of their 6 national projects for the next 2 years. And we'll be working in partnership with the Nial group to try and bring together what Nial are doing and improve the quality improvement aspect of that and what we've been doing, and try and fix those 2 projects together so that throughout the country people are exposed to quality improvement, leadership and those types of things to improve the quality of care they can deliver. There's a lot of thank yous to say. The ELC Collaborators group does not do it justice. I'm sure many people in this room have helped with this. But if I can remember all the names, there's Anne Pulley-Blank on the left from Bristol, Geeta Agrawal, who's sat across there. She's a major contributor to this project. Amazing work. Tim Stevens, Carol, I think I saw somewhere. Fantastic. Thank you very much. And Peter Carpenter, he's the subhead of the AHSN from KSS, who's been a real pleasure to work with and helpful. And he's been the major driver to get this adopted across the country by the AHSN network. I'm done.
And don't forget, you can meet the Top Med Talk team. All you need to do is turn up at one of our events. Check out EBPOM.org for more details. EBPOM.org. Our next big event is between the 28th and the 30th of September in Chicago. That's EBPOM USA, the Chicago Masters Course, Perioperative Care Practicum. Between the 28th and the 30th of September. EBPOM.org for more details. That's EBPOM.org.